So welcome everyone. I am Julie No-Smith, tonight's facilitator. So this is a webinar on healthcare over profit. Okay, so let me just start by introducing our organization, Healthcare Justice NC. So Healthcare Justice NC is a non-profit organization and a Charlotte chapter of PNHP, which is the Physicians for a National Health Program. That is a national organization. We advocate for a single payer universal healthcare system, also known as the improved Medicare for all. We have about over 4,000 members of physicians, nurses, community members, and students. We are united by the common principles that healthcare is a human right, must be free from corporate profit, and must be achieved through national legislation. We'll begin our webinar by quoting Andrew Whitty, the former CEO of United Healthcare Group. Quote, "No one would design a system like the one we have, and no one did. It's a patchwork built over decades. The health system needs to function better. The variety of state, federal, and private sector structures and programs have created a confusing, complex, and costly healthcare landscape," unquote. Normally, we don't agree with the health insurance companies, but here we are in full agreement with him. So our healthcare system is created to feed profit-driven corporate middlemen. And as a result, so many of us are struggling and hurting rather than healing. We'll talk about why this topic is important and how we can get out of this mess. So let me introduce the first speaker, Dr. Doug Robinson. Dr. Robinson is our current chair of Healthcare Justice NC. Doug is an endocrinologist and diabetes specialist, and he retired a few years ago from Atrium Health after 27 years of career there. Prior to that, he served 10 years as a medical officer in the Navy. Currently, he's a volunteer physician at the Good Samaritan Clinic in Morganton, North Carolina.
Okay. Well, thanks for that nice introduction, Julie. I'm going to try to give you the landscape of healthcare in America as it is right now, and then we're going to hear lived experiences from people involved with our healthcare system and experiencing our healthcare system in America. So let me just share my screen. This is the elephant in the room as we talk about medical debt, uninsurance, underinsurance, cost of healthcare, cost of pharmaceuticals. The elephant in the room is that fundamentally our healthcare system in America is broken. Now, some people might say it's broken. Other people might say it's working exactly as it was designed, but that's a matter of debate. You know, at this time and place in our political climate, it seems like it may not be a good time to talk about healthcare reform in America, but it actually is. People are activated about the quality of health and healthcare coverage in this country. And this is a Gallup poll from last fall, shortly after the CEO of United Healthcare was assassinated. And the opinion that people have about their healthcare and healthcare coverage in America is at a 20-year low. So people are more dissatisfied with their healthcare and their healthcare coverage than they've been in the last 20 years. Let me just make a few points about how our healthcare system is broken. We're the only developed country without universal healthcare. And our healthcare is more expensive than in any other major industrialized country in the world by twofold. We spend about $14,000 a piece per year, and yet we have some of the worst outcomes. So infant mortality, maternal mortality, lifespan, all ranking at the bottom of industrialized nations. And unlike other wealthy nations, we have this curious problem of medical debt. 100 million of us owe in total about $220 billion in medical debt. And we'll have some more talk about that later. Oddly, in this country, we treat healthcare like a market commodity, like there's transparent pricing and you really know how to comparison shop for your MRI when you've been diagnosed with your brain tumor. So it does not function as a true commodity. And then the other weird thing we do is we link health insurance to employment. So you lose your job, you lose your health insurance. We all know somebody who's kept that job at Starbucks to keep their health insurance. Where in other nations where they have universal health care, they go out and start their own coffee shop. You know, they don't have to stay working someplace just to get health care. Most of a large chunk of our healthcare spending goes to the insurance companies and intermediaries as profit and administrative costs. So about 30% of the almost $5 trillion we spend in healthcare. And then the way we do healthcare in this country is kind of upside down. We tend to focus on disease treatment rather than prevention. And a testimony to that is we don't have enough primary care physicians. This is the 2024 status of insurance coverage in the United States. You can see 9% of us are uninsured. A much bigger proportion of us are underinsured, and that means that they have high copays and deductibles that they can't afford. I want to just speak one more slide about uninsurance in the United States because this is a looming problem. So this is a slide that came out yesterday from Kaiser. If the budget goes through as planned with the GOP, we're going to add another 13.7 million to that 30 million that I just showed you that are uninsured in the United States. So uninsured people in the United States will go from 30 to $43.7 million as people fall off the Medicaid rolls and the ACA changes, things like that. So it's going to be getting worse. Underinsurance is that problem, the high copays and deductibles. This is in North Carolina. If you have a single person policy in North Carolina, you're spending about 10% of your median income just to have your health insurance. If you have a family, you're up around 12%. Once that number gets above 10% like that, that's underinsurance. And these folks avoid necessary medical care. They have worsening health, and a lot of them have medical debt. Inability to pay for care is increasing. 1 in 3 Americans don't have access to affordable health care. The most notable increases in people who can't afford health care, not surprisingly, low-income households and people of color. Where does our money go in American health care? Well, I talked about that 30% that goes to administrative spending, insurance companies, hospital billing staffs, physician office staff, and huge profits for insurance companies. These are the big 5 2022 profits. If you look at the CEO compensation over the last decade, it's in the millions and millions of dollars.
And now we're going to hear how the current system is working in our lives. So I'm going to start with Mr. Doug Devani. Doug is a librarian, researcher, competitive intelligence specialist. He moved to Charlotte from New Jersey about 3 years ago, and bad luck hit him. He has been involuntarily returned to the job market 3 times since 2021. Doug?
Hello, everybody. I'm Doug Devani. Glad to be here with Healthcare Justice NC talking about this very important issue. So I do appreciate the introduction from Julie. Now, why don't I currently have health insurance? Well, there are several key reasons. So first off, as Julie mentioned, I have been returned to the job market 3 times in the last, 3 years or so. So I'm much more accustomed to looking for stable work than having it. I've also encountered tremendous difficulty in securing a role in my field. I am a librarian by degree, a competitive intelligence specialist by trade, a bit of a niche field. Unfortunately, things have not worked out in terms of securing a role with stable income and health insurance. That's why I'm in this predicament. I've often earned far too much money to qualify for Medicaid, even with temp and contract work. I simply am outside of the bracket in terms of the people that they will cover. So that also has been an issue. Honestly, if I am being completely forthright, I have not devoted as much time as I probably could to searching for, suitable plans on the healthcare marketplace. Honestly, I've had far too much to do in terms of just paying the rent and keeping a roof over my head. So, as I alluded to briefly, I have done a lot of temp and contract work, and as the nature of this work implies an unstable income, I've not been able to make long-term financial plans a reality for me. So in terms of even things like healthcare spending for the future, that has also had to be on hold. So what are the serious effects that, are impacting me by not having health insurance? Well, first of all, I've not been to a dentist in several years on any kind of a regular basis. So as a result, I need 2 dental implants, which will cost about $12,000 out of pocket. I also need 2 root canals, which will cost me $3,000 out of pocket. Thankfully, I've had some very kind-hearted people who've given me some money for some temporary fixes, but again, it's only a temporary fix. I also am aware that there are certain health screenings that I will soon need to, have done for myself as a 45-year-old male. And I, at this point, do not know exactly how I will be able to afford getting those health screenings done. That definitely is an issue that weighs on my mind. But at this point, it's just not anything I can really, do anything about. I also have done what I can to cut corners. Doing everything I can to avoid getting sick, taking over-the-counter medications and hoping they work as well as prescription supplements. Also using websites like callondoc.com, through which I was able to get diagnosed online for $40 and get some pills for $10, which was a blessing. But I must tell you that I definitely was panic-stricken, wondering how I was going to be able to afford my medication for a recent internal issue I had. So, really, for me, what it's come down to over the last several years is being in survival mode. And unfortunately, given that stark reality, being able to address my healthcare needs in any kind of a concrete and organized fashion has simply not been possible. I'm just doing the best I can to survive. Thank you.
Yeah, the fact that the healthcare system here is a link to employment status, as Doug alluded. Some people, they work full time, but they cannot get the insurance because the employer is more than not, they don't hire more than 50 employees. So there are a lot of loopholes. Doug is just falling the crack, sorry. And thank you for sharing. And next speaker is Mr. Mick Edwards. Mick is the owner, CEO, president of Steel Point, which is a metal fabrication, trailer design, and manufacturing company in Matthews. Steel Point has been selected for Inc. magazine's 5,000 fastest growing businesses in the U.S. for several years. The company has about 70 to 90 employees at a given time. Mick?
Yes, good evening. It's a pleasure to be with you all. I'm here to really sort of talk about the cost of healthcare and the system as we see it as you run a company. Every February, we have the privilege of expecting the expected, which is when we renew our insurance for our employees. We face somewhere between a 5 to 8% minimum increase every year. We made a commitment that we would basically pay pretty much most of our employee insurance. So they only pay $22 a week, and we pick up the remainder. So in 2023, we paid about $411,000 to cover that for 70 to 90 employees. This year, it'll be about $460,000. It is incredible to me that we are put in a position as somebody who's running a business that you're actually in charge of people's healthcare. And when we come up to these renewals, when you realize that out of an employee base of 70 to 90 people, it only takes one person to have a cancer or some other incident, and you're already being profiled, and you know you're going to get more of an increase. And we have had that. It's pretty alarming to me when you get a 62-year-old male who comes into your office in tears because he thinks you're going to fire him because he's got cancer. I find that shocking. But to me, it is an incredible system. I've been fortunate. I've lived, and obviously you can tell by my accent that I didn't really grow up in America, but I've lived here for a long, long time, since the mid-'80s. And I believe that these costs are incredibly out of control. There is no control. And we're forced to basically pay the costs. And when I look at, there are in the top 50 companies in the Fortune 50, 7 of them are health insurance companies. And they've spent over 120 billion in stock buyback since 2010. I find that incredible that they can get away with that. Warren Buffett was right. The healthcare cost is a tapeworm within the US economy, and it is making it uncompetitive. And when you look at how other countries run and the cost that Doug referred to earlier, it is, in my opinion, a totally it's basically an unsustainable system. And we need to find something else. And Medicare for all or improved Medicare is the solution, I believe, that we should look at. Thank you for your time.
Thank you, Mick.
Yeah.
Next one, we are going to watch a video clip of Terry's story. Terry Belk, he's a resident of Charlotte. He really wanted to join us tonight, but in person at this meeting, but his work finishes too late for this meeting. So we're going to watch a video clip.
Thanks, Julie. I'm going to set that up for you with an introductory slide about why we have this curious thing of medical debt in the United States. Again, it goes back to our unique health insurance in this country, and people accumulate medical debt because they don't have health insurance. Or most people with medical debt these days are actually underinsured. They have health insurance, but they can't afford the co-pays or the deductibles or the uncovered items. Cost for prescription drugs is 2 to 3 times what other nations pay. Many health plans lack comprehensive coverage. And then insurance companies increase their profit, I hate to say this, through denials of care. And then, of course, our healthcare insurance system is so complicated. There are 1,500 insurance companies in the United States. There's 10 administrators for every healthcare provider to help with billing, so that there are, by design, billing errors and insurance complexity. So I'd like to go on and have you listen to Terry Belk's story about his experience with medical debt.
I watched my wife die, and these people still came at me and her as she was dying for money we didn't have. Not saying we didn't owe it, but it should have been a better way to collect it than what they were doing. This is a national crisis. This is not just affecting North Carolina. This is nationwide, and hopefully this becomes a movement. My late wife was diagnosed with breast cancer in 2003. We had private health insurance, but it wasn't adequate to cover all the bills. So we were shocked a few months down the road. We get this big gigantic bill from the medical providers saying that we owed $23,000 that the insurance company didn't pay. About a month and a half, we get these letters and phone calls from their attorney threatening to take us to court, to sue us, put a judgment on us and all of that. She said, why are they doing this to us? To us, that was a lot of money, but to them, I'm sure it was pennies. And several months later, she subsequently passed. Fast forward in 2010, I was diagnosed with prostate cancer. I had private health insurance there again, and it wasn't adequate to cover all the bills. I'm paying on the prostate cancer bill, and I am probably going to take this debt into the afterlife. The only way that this is going to stop if people speak up, speak out, and advocate for better. I'm in this because I lost love of my life. And I feel her spirit with me every day, and I know that she wants me to stay in this fight, and I will.
It's a heartbreaking story, but he's not the only one. So next speaker is the Dr. Michelle Stowe. Dr. Stowe is an internist with a specialization in geriatrics and integrative medicine. She has worked at various hospital systems, including Memorial Hospital in Statesville until last year. Currently, she is serving as a medical director at the Pines, a continuing care retirement community in Davison. Michelle?
Thank you, Julie. And your stories, y'all, thank you for sharing your stories as business owners and patients. I'm a physician of 30 years working, still at it. I feel like a rare bird. I'm third generation. I watched my grandfather start in family practice, my father a specialist in GI. So I've seen medicine not only through the course of my eyes, but their lives. And I've seen how much it's changed. I went into medicine, I think most of us do, because we want to help, we want to serve, we want to be with our patients. When I started 30 years ago, I spent 90% of my day with my patients, 10% on paperwork. I had one secretary and one nurse and me. I am now 30 years in. Julie always asked me to maybe come up with a story. I just look at yesterday. Yesterday, I spent 78% of my time on computer work and paperwork. And the rest was patient time. That's how much it's changed. And I think a story that needs to be told is, well, why are we doing that much paperwork? It's not because we like to do paper. I don't want to sit at a computer, but why actually are we? We are asked by insurance companies to do this computer work to make sure they get reimbursed for our work. So we're not just coming up with things to do on the computer. We are being told what we have to do on a computer. We are told to call the insurance company. We are told to get a pre-authorization. All day long, we are called to do something that is really not patient-focused. Second, I was asked to comment on the pre-authorization, which is a tiny piece, but yesterday I had two pre-authorizations. I see the elderly in a nursing home setting now. It's a little more peaceful than hospital work, but these are mostly residents that are wealthy, that have insurance, and there were still two pre-authorizations. One was for a hemorrhoid cream, okay? 20 minutes because they wanted to pre-authorize a hemorrhoid cream. This is just yesterday. I was also asked about physician burnout, and I had a conversation with a geriatric psychiatrist yesterday up at Harvard, and he's got a good point. Part of our burnout in medicine, he feels, is that we have no control. I went in medicine to help heal. I went to help the patient, not serve an insurance company or computer. We are not in control. I would agree with the prior speakers. I think this is a train out of control that we need to take a breath and reassess. Finally, I'd like to just say that I have seen a better system. I saw a better system when we started. I saw a better system 10 years ago. This is not acceptable. It's not right. And we need to change now. So thank you, Julie, for letting me speak.
Thank you, Michelle. Thank you for joining us. Our next speaker is interesting. He is a CPA. He is a finance guy. And why he is here? So he is a finance director of town of Hillsborough in Orange County. And Dave McCall, he has 26 years of local government accounting and finance experience, 19 years of which as a finance director and officer in North Carolina. And he's a CPA and has also worked as an auditor for accounting firms that prepare financial statements for local governments. So Dave.
Thank you for taking the time to listen to my story. I am a finance director that has about 19 to 20 years experience in the public sector, and I was also responsible for developing budgets to be adopted by our town boards. And one of the things we always would have to concentrate on is, all right, how much we're going to be able to pay our staff the next year. What increase can we give them based on a merit-based system? Then every year, about halfway through the budget cycle, we sit down with our health insurance broker. We sometimes wasn't bad news, but other times outlandish increases in our insurance rates for the next fiscal year. So many times we had to reduce the amount we were going to pay our employees for the next year to be able to cover those healthcare costs. And I realized at that time that our system is crowding out and repressing the salaries of many of our employees. And they probably don't even realize it's doing that to them. So then I went down the journey of comparing systems. I looked at the Western European systems and the Scandinavian systems, and I wanted to compare their costs and their results and compare it to what we have, the system that we currently have in this country, which I at one time fully supported. I'm ashamed to say that now, but at one time I thought it was the best system in the world because of me being naive. So after doing that comparison, it quickly came to my attention that the most fiscally conservative and responsible thing to do is to switch to a single payer system where the data doesn't lie. We're paying per capita twice as much as our European counterparts, but our life expectancy is 4.7 years less, or 4.5 years less. We spend nearly 18% of our GDP on healthcare. Our European counterparts spend between 11 to 12% of GDP. So you just do a little bit of analysis. If we were to switch to a universal healthcare system, bend the cost curve in healthcare, and bring our expenditures on healthcare, make it at 11% of our GDP, like our European counterparts, we would save well over $1 trillion a year on healthcare costs. And that $1 trillion, where should it stay? In our hardworking people in this country. It should stay in their pocket instead of flowing to the income statement and balance sheets of a company like the United Healthcare Group. It would also reduce the federal deficit over time by bending the cost curve. We wouldn't hear these stories anymore of medical debt. They're excruciating to hear. People going bankrupt just solely because they got sick and they had unsustainable bills that they couldn't keep up on. We would we'd also save probably about 68,000 lives a year. It disgusted me to see that studies show that 68,000 people die prematurely solely because they either don't have access to good quality care because they either don't have insurance or they're underinsured, and that's disgusting. You take that over a 10-year period, that's 680,000 people who we lose solely because we have an inhumane system. So it took me searching and seeing the light and realizing how wrong I was. And all I can say about our current system is that it just isn't right. And that's my story.
It's an amazing story, Dave. Thank you for sharing that. Our next person is Travis Archie, and he is a brave man. He and I talked together, and we talked twice to Representative Harrigan's office about the harms of impending Medicaid cut. Because Travis Archie is a single father with 4 children. He is on Medicaid. Until very recently, he worked full-time at a medical building company. Travis, share your story, please.
First of all, thank everybody for giving us your time tonight to hear these stories. And second of all, Miss Julie, thank you for introducing me. Um, but so yeah, I'm on here tonight to talk about because I come from a place where not only do I work in the healthcare system, but I'm also a person who needs the healthcare system to survive. I suffer from chronic heart failure, which is a hereditary disease that was passed down from my father and my grandfather. So knowing the fact that Medicaid is potentially getting ready to be removed from our system is devastating to me because I kind of need that insurance to help myself live. As Ms. Julie stated before, I have 4 children, and all 4 of my children are active in sports. This past fall season, my daughter was playing softball, and it was very hard for me to obtain my medicine at one point in time. So it was very scary for me to be out there because I was afraid that my child would actually see me croak over if I got too excited because that's just how bad my heart is without the medication. Um, and what's even sad about the whole situation is that whenever you get paid and you have to sit here and decide whether I feed my family or do I buy my medication? Because Medicaid don't cover for all these expenses like they say they does. And sometimes even you get denied when you have that med for so long, you look up and all of a sudden now that insurance that you was relying on no longer covers your medicine. When my insurance company let me know that they would no longer be covering my heart medication, I had to pay upwards to $11 per pill just for heart medication. Guys, I know that y'all don't know me, but I barely make $1,600 a paycheck. I barely even crack the $1,300, and I work in healthcare system. That should let y'all know how hard that hurt. And I have to sometimes get between 90 and 120 count pill just so I would not be running up my bill going back and forth to the cardiologist's office to obtain just a visit. Because if I do, it will not be covered for the other times. So whenever you have to choose between medicine or taking care of your family, that should let you know where this world take place at or where it stands as far as what our insurance is doing to us as a family. And I represent every other American that's on this call that's probably going through the same thing. You know, we're tired of having to decide whether we feed our family or choose to live. But then if we choose one or the other, in my case, if I don't feed my kids, then all of a sudden DSS is getting called on me because they're malnourished and stuff. You know, it's like a trickle down effect that you have to deal with because you decided to get your medicine. But then on the bright side, if you do feed your family, then you know, good luck surviving without your medicine. I don't know what this future may hold, but I do know that this is not right, and us as America need to get it together to come up with some type of common ground. Insurance companies shouldn't be this greedy. They shouldn't. And I'm not even going to bring in my race because that's a whole nother hour I could stay on this call just talking about what I have to go through as an African American to even get the decent insurance. But that's a whole nother story. I'm only here tonight to let y'all know that it's not right what we as Americans have to go through. You know, we should all have access to free healthcare. We should all have the dignity to know that if I get sick, that I won't have to put up my house in a car just to go get a band-aid. Um, this is a really emotional topic for me because I've always believed in the healthcare field. When I first started in the healthcare field back in 2013, when I graduated from the Liberal Arts Institute as a medical assistant, I was one of those enthusiastic new grad students. I mean, I'm gonna get out here. I'm gonna save the world. I'm gonna get out here. I'm gonna make sure this person have this, that, and the third. But then you get out here in the world and you realize that a lady no older than your grandma can't even afford her medicine because the insurance company jacked her premium up another $500 after she just sat here and paid $600 the month before. So once again, I don't. All I'm asking is that America, we get it together and get it right. And you know, until that happens, it'll be a lot of our friends and other people that's going to pass. And I believe that the insurance companies should have that blood on their hands if they continue to let this happen. Thank y'all for your time.
Thank you, Travis. Hard story to even hear. So we'll go back to Doug Robinson, and he will share. So how do we get out of this mess? Can you share the solution?
It is a mess. And we think, as advocates for universal single payer healthcare, that the answer is right in front of us. Let me share my slides here again, please. We think the answer is what we call improved Medicare for all. Medicare is a very popular healthcare insurance for seniors and the disabled in this country. It is not perfect. You have a 20% copay for your outpatient insurance. And there's some issues with drug coverage, but it's very popular. The overhead for Medicare is about 2% compared to 18 or 20% for insurance companies. If we rolled out an improved version of Medicare to everyone in the United States, it would look something like this. It would provide all medically necessary care with no copays, deductibles, or premiums. We call that free at the point of care. That need for supplemental insurance, that Medigap insurance I talked about, would disappear. It would be funded through a progressive taxation and a simplified payment design that wouldn't require all the complexity that we see with commercial insurance. It would cover inpatient, outpatient, all medications, mental health, vision, dental, hearing, long-term care, and comprehensive reproductive care. So commercial insurance now has narrow networks of hospitals and physicians. We talked about the premiums, deductibles, and copays, the prior authorizations, the denials of care, the delays of care, all those shenanigans that commercial insurance companies go through to increase their profit margin. And then, every year the coverage changes with your job. It's just incredibly complex, fragmented, inefficient, and terribly costly. Whereas Medicare for all, you would retain your choice. You'd be able to go to any hospital or physician in the nation. To be clear, we are not talking about a national health service like in England. This is universal single payer healthcare paid for through progressive taxation, but you would retain your ability to see any physician you wish, just like when you're on Medicare. All care and drugs would be provided free at the point of service, and you'd have lifelong coverage with no interruption in care. As we were going over the insurance statistics of people in the United States, I didn't talk about people who experience a break in coverage of their care. And that can be devastating for someone who's currently undergoing treatment or has a chronic disease. Gaps in insurance coverage like folks experience as they change jobs can be devastating. As I said, this slide's a little repetitive. Medicare for all would include everybody residing in the United States, regardless of age, income, employment, or immigration status. You would not be denied due to pre-existing conditions, and you would have choice. Very important. Where Americans love choice, you would have choice to go to any doctor or hospital. Can we afford universal health care? The answer is yes. 95% of households would pay less in taxes, what now is their Medicare premium, than they currently pay in premiums, copays, and prescriptions, and will have full comprehensive coverage. So this is some broad brushstrokes about how it could be paid. As other speakers were saying, there is cost savings to be had if we do universal single payer health care. And we estimate we could save 500 billion in administrative cost reductions, about 150 billion through negotiated drug prices, and that gets us 650 billion that we can use for vision, dental, removing the need for co-insurance in Medicare, and then we'd actually save 325 billion. Most physicians would be paid about the same. Perhaps some highly reimbursed subspecialties would see a decrease in their reimbursement. Most Americans support Medicare for all. This is an April 2020 poll. 69% of registered voters supported Medicare for all. Higher percentages, you might guess, for Democrats. It's very popular with younger Americans. And in 2017, 56% of physicians supported Medicare for all. So, the 2025 Medicare for All Acts just came out. So there's one from the House and one from the Senate. The House was co-sponsored by Representative Jayapal and Dingell, and the Senate bill by Bernie Sanders. So we have 105 co-sponsors of the House bill so far. 2 of the 4 Democrats in North Carolina have signed on as co-sponsors. And in the Senate, there are 15 co-sponsors. It's identical to the 2023 versions of these bills. If you want to contact your legislators and ask them to become a co-sponsor, just scan this little QR code at the top there, and that'll give you a link to find out your contact information for your legislators. If your representative is Alma Adams or Valerie Fouché, contact them anyway and thank them for being a co-sponsor and ask them to be more public in their single payer advocacy. Put it on their website. Continue to talk about it. If you'd like a more in-depth summary of the Medicare for All Act, you can scan this lower QR code, or certainly if you want to get online, you can actually read the bills themselves. But this is a very nice in-depth summary about the Medicare for All Acts. I would be remiss if I didn't circle back to this urgent issue as the 2025 GOP budget threatens large cuts to Medicaid and transferring a lot of the costs of food stamps, the Supplemental Nutrition Assistance Program, to the states. Large numbers of Americans depend on SNAP to put food on the table, and they depend on Medicaid for life-saving health care, and that's about to be ripped away in large numbers, the numbers that I showed you before. If you call this phone number, that'll get you the, you'll give your zip code, and then you'll get a phone number of your legislator. Phone messages are powerful ways to tell your legislator to keep your hands off Medicaid and SNAP. They have to record that you called. So burn up those phone lines. Call every day. Perhaps the most vulnerable politician you might want to call, who we think would have some movement on this issue, is Tom Tillis. Tom Tillis is up for re-election next year and is in a vulnerable position and is probably poised to hear more about this issue. So if you call Tillis's office and say, do not touch Medicaid and SNAP when those bills go to, when the 2025 budget goes to the Senate, which should be, it'll probably be in the next week or two.
All right, thank you. Thank you all. Healthcare Justice NC, together with the several other groups here in North Carolina, organize a rally. First, not this coming weekend, but the following weekend in Charlotte. This is called Rally for National Single Payer, People Over Profit. And this is part of a National Day of Action initiative for single payer healthcare. So throughout the country on the same day, there will be protests and rallies and all sorts of events throughout the event. So we will tell the government that current healthcare system is broken beyond repair. So we demand that people-focused national single payer to be put on the nation's agenda. So, currently the corporate healthcare is being really kind of highly respected, but people over profit. That's what we are demanding. And people can sign up and show up with your friends. And that's on Saturday at 11 o'clock at the Mecklenburg Government Center in Charlotte. While we are developing this rally, preparing, we realize how much things cost even. So as a nonprofit small organization, we're just struggling. So if you would like to support what we're doing, like an education program like this, and then the movement, we would really appreciate if you can just donate just even small amount. If anybody has any questions so far.
Catherine has her hand up, Julie.
Okay.
I'd like to say that I'm working with Julie and Doug and other people, Krish and others, on this May 31st rally. I want to make sure it's Saturday, May 31st. And it starts at 11 a.m. And we need people to start showing up about 15 minutes early with friends. So if you would go on your emails, pull up your contacts, and notify them right away that you were just on this webinar and that you would like for them to come with you, meet you there, whatever. Because we need people talking to people to get them to come. Because Julie has worked, I cannot tell you how hard, getting a great lineup of speakers. Many of you know who they are and are the ones speaking. So I would like to make sure that everyone gets there and can hear. We have a great audio system so everyone can be heard. Doug is emceeing. It's going to be really a great event. I got a call or email from former Mayor Pro Tem Betty Chafin. She's having guests that weekend and is bringing them. I want people to do what my friends do and not only bring themselves, but get them to bring other people.
Yeah.
This thing is going to be powerful. This event is powerful. It is important, and we need to be there. The address is on 4th Street at the Government Center, downtown Charlotte. It's toward the square, just next door, really, to the courthouse.
Yeah, so there's Amy's question there. Thank you, Catherine. It will be really fun and exciting event, and there will be three things. There will be speeches, and we have a whole lot new speakers as well. Some of current speakers will be there as well, but a lot more. And then there will be really interesting music. We will have a Raging Grannies from Greensboro. And then we have a professional singer there. And our keynote speaker will lead us to take action right on the spot. So it will be combined all and really compact event.
Julie, we've got a couple of questions in the Q&A box.
Okay, so can you say that, read that, Chris?
Yeah. So one is from Kathy Haddon. How do you respond to people saying that medical coverage for all in other countries is struggling? I don't know, Doug, do you want to take a stab at that?
Yeah, and Kathy has her hand up too. I'm going to allow her to talk, so maybe we can have a discussion here. So, Kathy, I'm not sure what is meant by medical care for all is struggling. I know that the National Health Service in Great Britain is having some problems. I'm not entirely familiar with the topic, but I do understand some of that is due to allowing commercial for-profit uh, health insurance entities into their system. But that's the only one I've heard of, is the national health system. Perhaps you can shed some more light on that, Kathy.
I've heard of that one. And then I think I've heard that the Canadian and the French health systems. And when I talk to friends about this, that's what they often throw back, that, oh yeah, those are all going bankrupt. They don't have any specific data, and it's not research based, but that's what they say.
I am not aware of that. Typically, what you hear when you hear people talk about the Canadian system is that there can be some waits for care, and that there may be more triage. So you won't get the MRI for that headache right away. But if you look at their health statistics, they're better than ours. So they must be doing something right. So and the physicians there seem to be quite happy with the program. But I think that's all I have to say about that. Perhaps one of our other attendees, I don't know, Dr. George Baumfach, the immediate past president of Healthcare Justice, is on the webinar. George, go ahead and raise your hand if you got anything to add to that.
I can add a little bit real quick, if that's all right.
Yeah, go.
So just from my experience and my knowledge, it's my opinion that universal healthcare benefits every person in the United States for a few reasons. One being that studies by institutes like the Economic Policy Institute, as well as the National Institute of Health, have actually found that universal healthcare policies, when done right, improve the economy for the United States. In other words, it's not exactly going bankrupt, it's actually helping the people. It's decreasing the wealth disparity, and it's creating better access to healthcare. I think there was a stat from the Harvard Institute of Medicine that found that one person every 12 minutes in the United States passes away because they couldn't afford healthcare. So, in contrast, that's completely in contrast to systems like Canada, where there may be longer wait times, but every single person receives adequate care. So it comes down to a question: if adequate care for some, as we have in the United States, if good care for only a few people that we have in the United States is better than adequate care for every person who won't have to worry about debts from healthcare. So that's just my 2 cents on it.
This is Mick Edwards. I've got a little bit of a knowledge of what goes on in the UK, and it's certainly not going bankrupt. If they argue that it's going bankrupt, it's not. And I'd say the same with Canada. Are they underfunded? Yes. In certain cases, they have been underfunded because, other sort of budget priorities, etc. And the easiest way to cut it is hold back on healthcare. One of the great things that you'll see in these countries is, though, that most people believe in the system, the healthcare systems they have. They're highly critical of governments that do cut funding to healthcare. And yes, you might have to wait, but the critical thing is what you don't see in, say, the UK and Canada is that person who's 65 to 85 or 95 having to worry about healthcare debt. And if they're not going to be able to see a doctor, you might have to wait a little bit, but you'll get the service. And that is a much fairer system than some of the stories you've heard here tonight. So they're not going bankrupt, but you might have to wait a little bit, but you won't have the debt. And that's my 2 cents.
Yeah, if I can add a couple more points there. The most important takeaway tonight, looking at our panelists and their stories, this current system impacts everybody. Everybody in this country. It's not racial issue. or it's not political issue, or even economical issue. Even you have money, still very expensive. And then I've worked on international side of health policy during my professional life, and seeing different models internationally, and various models, and what they are different from here is it's a lot cheaper. It's a lot cheaper, like less than half, and everybody covered. They don't worry about this kind of thing. There's no country that went bankrupt with health budget. And it, for example, like a Canada and Germany, they may not directly, government pays everything. Like they have their own like employees and pay it, but government plays a very important role to control the cost and streamline the process. That is a big difference. U.S. government is not doing much role. It's all everywhere. Insurance companies and private drug companies set their own price. There's no government control. That is a big difference. So I think there's no perfect system, but if you look at the big picture, what is the cost versus benefit that we get? Is this the current system in the US? Is this what we want at that cost? If we really care about the spirit of Dodge, government efficiency and cost saving, this is the area we really need to cut the cost and make it efficient and make it work for everybody. And
I like to ask a question to that lady who just did the question. I'm sorry, I forgot your name. But if nobody did their research or actually know for sure, then why are they allowed to tell you things that's just opinionated? Because opinion is neither false nor true. And this is no disrespect with me asking you that, but I'm not gonna believe my friends because Google is free, and not only that, it's other things that can lead to other resources that research can be simply done. And I may not have a PhD, but I do know that those other countries, they thrive, or not thrive in the way of like multi-billionaire companies, but I do know their healthcare system is better than ours because I actually work with a nurse now who just came from the UK, and she was on the phone with her husband not too long ago, just seeing what can they do to get back over there and how long his contract is going to be here in America because she was just so fed up with how we was being done here compared to over there.
I totally agree with you. And what I think, I really think that I need to take some snapshots of some of the facts about how one payer, how much we save, versus, the cost of our current system. And these people, I hate to be political and stuff, but I just feel that they're on a different system than I am, and I don't even want to talk to them anymore about it or invite them to things like this. They're pretty closed-minded.
That's why that was because why I wanted to create program like this and invite people like David McCall, and they can hear from a fiscally conservative person.
Mhm.
And
Right.
changing his heart, just knowing the facts.
Can I just say something too? I think where we do make an error as people, because now I'm no longer part of the Republican Party. I'm an independent. And just give you my perspective, but I do think we need to talk to other people who think differently from us. That's what's bringing down our country, in my opinion. And I respect your opinion, Kathy, but I also think that on my journey, that changed my opinion, it wasn't just stats. I didn't have enough time to talk, I only had 3 minutes. But I spoke to other people who had a different opinion than mine, and instead of talking over them after they gave me why they believed the way they did, I just listened. And I thought about what they said. And the combination of that, listening to somebody who has a different perspective than me, and also doing a little bit of research on my own is what changed my opinion. So I think we need to listen to each other. I know there's some people that just aren't going to want to listen, but I'm living proof that I listened and I looked and I had the empathy for other human beings. I see some of these stories here and it breaks my heart. And when I read that statistic that I read, 68,000 people a year estimated to pass away prematurely just because they don't have access to healthcare. That's not an acceptable system, in my opinion. And I think it's hearing these stories and talking to people who are Republican or conservative. We need to do that, though, I think, because we need some people to reach across the aisle to get some type of legitimate, some very good legislation. I know this country's kind of maybe broken right now, but I think talking to each other is a step to help our country heal, in my opinion.
Mm-hmm.
Yeah, thank you.
Doug, you got some other raised hands?
Julie, we have George Baumfuck, the
Okay.
immediate past chair of Healthcare Justice, has his hand up. Maybe you could shed some light on this. I'm going to allow you to talk, George.
Yeah, sure. Thanks. And first, thanks to all of y'all for participating in it. Of all the webinars that we attend about healthcare, this is one of the most lucid and clearest and emotional from all the stories. So thank all of y'all for participating. The question, when Doug suggested I say something, had to do with the complaints about other countries. And there's a gentleman, a national journalist out here in Colorado who's involved with the Colorado organization that's allied with BNHP, looking for a single payer. And he wrote a book several years ago called The Healing of America. And in it, he went around the world investigating the healthcare systems of different countries. And one of the bottom line conclusions he made, there's no perfect system. People in every single country complain about their healthcare systems. It's never perfect. And the leading healthcare system by most assessments in the world is France's, but still it's not perfect. And they're always tweaking it and trying to make it better. So we don't need to find the perfect system. We just need to get on board with these folks who've figured out that a collective, publicly funded universal system works best for everyone. And I so often come back thinking about this to the example of fire departments. And I know there's a lot you can take away from this analogy, but almost everywhere you go in the United States, if you look at the fire departments, they're modern, they're elements of pride in the community. The fire trucks are all there and ready and working because it's a public service and everybody participates in it and everybody's harmed if the service is not up to speed. And so I think that's a perfect example of people talk about, oh, we can't have socialism. Well, fire departments are socialism at work. They're a social benefit. And I think healthcare needs to put itself in the same area, and we'll be a whole lot better. So thanks again to all of you.
Thanks, George.
Yeah, thank you.
And Doug, I think you said Margaret had her hand up.
Yeah, I'm going to let Margie talk here. Margaret.
Yes, in regard to comparing to other countries, you can always cherry pick because wait times vary from place to place and according to what it is you're waiting for. But I find that the idea that some people would be inconvenienced if we gave everybody access to healthcare is kind of a weak argument to start with. But there is a study that was done, and I think some of the authors were from the Physicians for a National Health Plan, where they compared what happened to the capacity when healthcare access was increased, when Medicare was put on, when Medicaid was put on, and when Australia put their universal. And they found out that the amount of less valued care decreased, and the higher valued care, the amount of it increased. And there was maybe a 4% increase in wait time. When you think about it, is really not that much of a wait time. So the history has been that this argument has always been thrown out and it doesn't hold water because there's a change in the way doctors operate.
Yeah, thank you.
Julie, there's one more question in the Q&A box. I don't know if you want to try to get to that or.
Stephen McCollum.
Yes.
Stephen is asking whether here it's important all players on this issue agree upon a single nomenclature to take forward to educate and convert the public. Is your improved Medicare for all the same as the Sanders Jayapal language? Can we settle on a common title for our cause? Single payer or Medicare for all or improved Medicare for all? Do we mean the same thing, Doug?
There's probably a number of different ways you could do universal or single payer healthcare, but for us, it seems like the simplest route would be to use something that works. And we know Medicare works. Most seniors are happy with Medicare. It does need to be improved in a number of ways. But for Physicians for a National Health Program and for healthcare justice, it seems to us that that would be the most logical step to have universal single payer healthcare. But you certainly could do it in other ways. But why rebuild it? Why we have something that works, that's popular, that saves lives. Seniors' lifespan go up when they're 65. You can see it on the chart. As soon as they get Medicare, their lifespan increases. So it just makes sense.
I mean, it is the national single payer is kind of very logical name, but Medicare for all is easy for people to understand. They can get it, what that means in healthcare policies. So it's kind of what we are stuck in between the two. And going forward, maybe we need to discuss that as a kind of a strategy. Thank you so much. And this has been wonderful to hear your stories and, have a discussion with the participants. And this is what we need to do more and with more people. And like David suggested, we need to listen to other side of the political view and then, get to learn how we can open their hearts and then create this common ground that we can make our healthcare better working for everybody. So thank you all and have a good night.